This conference will now be recorded.
So, good morning to all. I'm Dr. Vijay Shankar, Assistant Professor, Department of Orthopedics. So, today we are going to discuss about the bone tumors, two bone tumors, the osteoid osteoma and chondromyxoid fibroma. So, coming to osteoid osteoma, we will going to discuss in the following headings: introduction, incidence of the osteoid osteoma, sites of prediction and symptoms, gross appearance of this gross appearance of this tumor and microscopy, and we will deal with radiological findings and the differential diagnostic treatment part. Coming to introduction, osteoid osteomas are benign bone tumors, bone forming tumors. These are less than 2 centimeters in greatest dimension and usually occur in patient in their teens, usually in second to third decade of their life, and in 20s. In fact, 75% of the patients are under age of 25 years. So this osteoid osteoma can arise in any type of bone. Both they can involve both appendicular skeleton and axial skeleton. But these have more predilection for appendicular skeleton. So out of 100 patients, 100% patients, 50% of the cases involve the femur and tibia, where they commonly arise in the cortex of femur and tibia. So osteoid osteomas are painful lesions. So apart from other tumors, these are very painful. The pain is caused by excess prostaglandin E2, which is produced by osteoblast. So the characteristic pain in this is occurs at the night and dramatically relieved by aspirin. This is a very characteristic feature of these tumors. These are night pains will usually the pain will be at night and it is dramatically relieved by aspirin. So some of the special features of this osteoid osteomas are they have a spontaneous regression. So these sometimes fail to increase in size with time. So sometimes this regress and it is replaced by scar tissue. These features are unlike those of other benign tumors, such that etiology remains uncertain. So coming to incidence of this osteoid osteoma, these form around 10 to 11% of all benign bone tumors. So of all benign bone tumors, this form around 10 to 11%, and of all bone tumors, including these bone tumors, both benign and malignant, these constitute about 2.5 to 5%. So as I said earlier, these occurs in the first 3 decades of life, most commonly seen in the second decade of life, and mostly most common in males. So male to female ratio is 2:1. So as you see from this, the sites of predilection, the sites involved in mostly involved in osteoid osteoma. So most commonly, 50% of the tumors occurs in the diaphysis of femur and tibia. So and the middle side of neck of femur. And next is mostly here in the figure also you can see that it most commonly involved the upper femur, around the neck of femur and in diaphysis of femur, shaft of femur. Okay. And next commonly involved is upper end of tibia and lower end of tibia next. So and in the vertebral column is also axial skeleton is also involved. In axial skeleton you will see the posterior elements are usually involved. Actually the vertebral column is divided into anterior body and posterior transverse process and spine of spinous process. So the posterior element constitute posterior spinous process, transverse process, and this ala and facet joints. All these are most probably these are involved in the case of spine involvement. So next common bone involved is humerus in the upper limb. Humerus is the most commonly involved, and the phalanges of the hands, and these are least commonly involved. Phalanges, fibula, and in foot we can see thallus and ribs and skull. Most commonly we will see this osteoid osteoma in the case of femur and tibia. So coming to symptoms, the pain of this osteoid osteoma is a characteristic pain, and it is classically described as it is sharp, dull, boring, sharp pain, dull, boring, deep, and intense. It is often worse at night. So this is very sharp, dull, boring, deep, and intense pain. Often it usually occurs at the night times, and it is usually relieved by salicylates, mostly aspirin. Aspirin relieves this pain. So other features are with the osteoid osteoma near to joint. So if the joint is also involved, so she may have a limp, or if the pain is it is very painful, then you may have antalgic gait. So because of pain, you won't put the weight on this limb. So there is a muscular atrophy, disuse atrophy. It is known as disuse atrophy may occur. Muscular atrophy may occur. Sometimes you may, as the swelling increase, you may see the swelling and warmth if it is very superficial. So usually it is size is very less, 2 centimeters, and it won't grow. So in only superficial bones, you will see this swelling and warmth. So sometimes you may see the joint the stiffness may be there. If the spinous process involved, sometimes it may lead to scoliosis. So if it occurs in children, so there is a overgrowth on opposite side, and there is a angular deformities may occur in the case of children. If the spinous process is involved and it is involved and it is growing, then it may compress the nerve root, or it may compress the cord, spinal cord. Some on palpation we have notice a point tenderness over the lesion. Coming to gross appearance, as you can see from the picture, is a cherry red to gray red tissue. So this tissue is cherry red to gray red. So and overlying cortex is distorted. So we can sometimes see the reactive periastial new bone formation. So this nidus is an osteolytic lesion in X-rays. Nidus may vary from a few millimeters to 1.5 centimeter diameter. So surrounding a tumor, you will see a reactive bone formation, thick and hardened extension. So this is a histological picture of this osteoid osteoma. You can see the numerous osteoblasts. You can see the numerous osteoblasts forming a hairy irregular trabecula of osteoid and woven bone. This is a bone. Bone trabecula variably mineralized. There is mineralized bone, and the calcification more near to the center of the lesion. Sometimes we may not see any calcification on it. Sometimes surrounding bone shows reactive bone formation with a laminar bone in contrast to bone of nidus. We can see a thin zone of avascular tissue between the nidus and reactive bone. So if the patient comes with the pain and swelling, so first we will order for an X-ray. In X-ray, we can see so this is it is the APV of in this figure. You can see that here is the anteroposterior view of the leg showing a tibia and fibula. Here we can see a small lytic lesion here, surrounded by a thick sclerotic dense bone. thickened and dense bone, sclerotic bone here. So this is a, here we can see this is a cross section area of this tibia at the site of the lesion. This is the fibula bone, this tibia bone. This is a medullary cavity. Here we can see here osteolytic lesion surrounded by dense sclerotic tissue. So this is the part. So this is the osteoid osteoma. So in X-rays we can see a small to round oval focus of decreased density called, this is known as nidus. This is nidus. Sometimes this nidus is also sclerotic, and the surrounding nidus is a sclerosis which is normal reactive. So surrounding these things we may have a normal reactive. So these lesions usually occurs in a diaphysis. So most of the time there is involved diaphysis, mostly cortical. Most of the times these are involving cortical region only. This is a cortex. You can see from this picture, X-ray image. This is the cortex. This is a dense, radio dense area is in the cortex, and inside is the medulla. So most cortical, mostly it arises from the cortex. You can see here. Sometimes it inside the medullary canal. Sometimes you can see in the medullary canal. Most of the time it is involves only cortex. Sometimes medullary canal. Sometimes you may see this as a in a periosteal reaction. So if the periosteal reaction occurs, is large and large, but a smooth in contrast to Codman's triangle of malignant. It is very large and very smooth. So usually these lesions, osteoid osteoma usually occurs in this cortical region. Sometimes a medullary canal may be moved, and we may see the periosteal reaction around this uh, around this tumor. So coming to bone scan, the lesions of osteoid osteoma are very small. If they are not detectable on X-rays, then we will go for a bone scan. So in it, a double density sign, which is a focal area of increased activity with a second small area of increased activity. Increased uptake superimposed on it is called a, is said to be diagnostic. Here you can see it. In it the activity is very high, and surrounding that we have radiological radioactivity. So bone scans, double density sign in a bone scan is a diagnostic of osteoid osteoma. So if we can usually diagnose it by X-rays, and next if it is a very small lesion, so we can go with a bone scan. And if you want to further evaluate it, if it is not detectable on X-rays, we can go with CT scan. So CT scan is sometimes required to localize the lesion accurately. Okay. Sometimes if you have a osteoid osteoma in a vertebral column, vertebral bodies, or a vertebrae, then we can go with a CT scan. So here you can see a small nidus. This is a CT scan film. So this is the figure showing the this is the lateral view of this proximal leg, one third of leg, showing that this is a tibia and this fibula. You can see here very dense lesion in the arranging in the posterior cortex, and you can see here osteolytic, something like very dark is there. This is known as nidus. A dark central area contains a white nidus. This lesion in 20-year-old. So this as you can see here, the osteoid osteoma. A lateral view of the proximal tibia shows very dense lesion in the posterior cortex. Okay. A darker central area contains a white nidus. The lesion in 20-year-old man causes pain in this area, relieved by aspirin. So as it is a characteristic feature of this tumor, the pain gets relieved by giving aspirin. Bone scan. This is the X-ray. This is a bone scan. Different patient with an osteoid osteoma in the left lower tibia. You can see here. This one is a different patient. This is a different patient. So this is a bone scan of showing the pelvic region. This is a femur, knees, and here you use, compared to other sites, you can see the increased activity in the left tibia. So this is the right tibia, this is left tibia. You can see the increased activity in the left tibia. So bone scan will help in diagnosis of osteoid osteoma. These lesions are very small. So it is a specimen of radiograph of intracortical osteoid osteoma. So this is you can see here. This is the lytic lesion. This is known in this central round one. This nidus surrounding the thick cortical bone formation. So this is osteoid osteoma. Aspirin dose with raised beneath the periosteum. Tremendous amount. So usually we will see the tremendous amount of, if it is below the in cortical region below the periosteum, we will see the thick amount of reactive bone formation. This is a central area known as nidus. So the actual tumor known as nidus manifests radiologically as a small round deficiency that is variably mineralized. So we are saying that osteoid osteoma gets relieved with aspirin. Why it gets relieved with the aspirin? So in osteoid osteoma, we will have a high levels of prostaglandins. So these prostaglandins will mediate the pain receptor pathway. So pain receptor pathway. So this aspirin acts as a prostaglandin synthase inhibitor. So in the case of osteoid osteoma, aspirin relieves the pain caused by osteoid osteoma. So what are the differential diagnosis of osteoid osteoma? The lesion, we can differentiate it from osteoblastoma and osteo. So differential diagnosis would be osteoblastoma, osteosarcoma, so eosinophilic granuloma, Ewing sarcoma, Brodys abscess, and stress fracture. So this osteoid osteoma and osteoblastoma are same, almost same, but as tumor site differentiate both these things. In osteoblastoma, it is more than 2 centimeters, and they usually have high risk of malignant transformation than osteoid osteoma. So next, coming to, we came to a diagnosis, and we know that it is osteoid osteoma. So now the treatment part. What to do with this osteoid osteomas? So first we have to remove this lesion. First, we have to remove this lesion, and we have to relieve pain. And secondary manifestation, like if any scoliosis or nerve root compression, we have to relieve the pain. The nerve root is involved, then we have to do decompression of the nerve, and in scoliosis we have to do the scoliosis correction. In synovitis we have to do necessary synovectomy. So principle of surgeries, in the case of osteoid osteoma, I have to remove the nidal tissue. So I have to completely excise, remove all the nidal tissue. This is the principle of the surgery in the case of osteoid osteoma. So surgical options are, so block resection of nidus. So en bloc resection of nidus can be done. So this sometimes if you remove en bloc, then there may be increased risk of subsequent fracture. The lesion is in the cortical bone. So we have to be very careful. So for this thing, alternative method is that we shave the reactive bone with the sharp osteotome until the nidus is exposed. Then after nidus is exposed, then we curate it with the bone curates the excise and expose the exposed nidus. So we'll remove all those things. So how will you localize the nidus intraoperatively? So we have to localize the nidus intraoperative nidus of osteoid osteoma intraoperatively. So preoperatively we will inject with a technetium labeled methylene diphosphate. So this diphosphonate. So this will go to the osteoid osteoma site and nidus, and we can see this on CM images or intraoperative access of excised specimen to document complete removal. So intraoperatively, what you do is we'll inject preoperatively inject technetium labeled methylene diphosphonate. So at the time of operation, we can localize it. We'll take an X-ray, we will localize it, and we'll remove the part which is affected with the osteoid osteoma. So sometimes if it is a very small lesion, we can do with the CT assisted localization. So here you can see that the lesions around in this area, this cortical area. So in this CT assistant, with the help of CT, we'll keep a cable. We'll keep a cable inserted into the nidus. Then we'll take a biopsy with a biopsy punch over the cable and percutaneous CT. So later, percutaneous CT guided resection can be done using a tripine 2 mm larger than the lesion to ensure complete removal. So first we will keep a cable CT guided we'll see on the CT, and we'll keep a cable, and on the cable we'll keep a biopsy punch, and we'll take a biopsy from that, and then we will do percutaneous resection of this nidus and osteoid osteoma. So recently something known as radio frequency ablation. So this is a very simple procedure. So post-operative morbidities are less and sutureless. So this procedure can be done percutaneously. Initial core, as previously described, core needle biopsy is done, after which radio frequency electrode is inserted to the cannula of biopsy needle. So temperature at the tip of the ear is raised to 90 degrees centigrade for 6 minutes. So the results are equivalent to surgical excision, but this radio frequency ablation is usually used in extraspinal lesions. That is, in the case of appendicular lesion, if the tumor is in femur or tibia, then we can use it. In the spinal lesions, we can't use this because there are more neurovascular structures very near to this spinal process. So coming to conclusion of osteoid osteoma, osteoid osteomas are considered benign and normally treated by conservative surgery. However, there is a possibility of very rare possibility of malignant transformation. So this is a rare except when treated with radiation, which promote this complication. The characteristic feature of this osteoid osteoma is pain, which is relieved by aspirin. So coming to next tumor, chondromyxoid fibroma. So it is a very rare benign cartilage tumor. So in this cartilage tumor, you may also have a myxoid and fibrous elements too. So it is named as a chondromyxoid fibroma. So you can usually see this in the case of second and third decade, and male to female ratio is 2:1. So predilection of this chondromyxoid fibroma, it is usually seen around the metaphysis of the knee joint, usually in the proximal tibia, proximal fibula, and distal femur. So coming to the gross anatomy, resembles fibrocartilage cartilage grossly. It has a sharp border, often with outer surface of thin bone and periosteum. So the glistening grayish white lesion is firm and lobulated. It may also have small cystic foci or area of necrosis, hemorrhage. So this is a histopathological slide showing in nodules or cartilage are found between fibromyxoid area. In some field, the loose myxoid dominates. In others, dense chondroid dominates. There are also more cellular zones of tumor with some giant cells at the edges. So coming to clinical features of chondromyxoid fibroma, this patient may have a chronic pain and swelling and possibly a palpable soft tissue mass. And if it is more nearer to the joint, they may have a restriction of joint movements. So, how will you diagnose the case of chondromyxoid fibroma? We'll first ask for the X-ray of AP and lateral view. So, this is the figure showing the X-ray of a pediatric patient, as you see, AP and this is a lateral view. This is APV and this is a lateral view. So, this is a pediatric patient. We can see here that first is not fused, so we can say it is a pediatric patient. So, we can see the osteolytic well-defined lesion in the metaphyseal region of this lower extremity, in the tibia, upper one third of tibia. Here also you can see it in lateral view. So these are eccentrically placed. They are not centric. They are eccentrically placed. So you can see here eccentrically placed lytic lesions. So here you can see that these are lytic lesions. Here bone is very dense. Here it is. You can see it not very dense. So these are lytic lesions. We have clear defined margin here, as you can see here, clear defined margin, and usually involves in it is the metaphysis of lower extremities. So these clear margins with the sclerotic margins are there. So the lesion usually has a sclerotic margins. Sometimes we can see here ridges and margins are grooves are there in this tumor. Sometimes we confuse with the trabecula, falsely appear as trabecula. These are known as pseudo trabeculations. So eccentrically placed lytic lesion with well-defined margins in the metaphysis of the lower extremity. The lesions usually has a sclerotic margin in bone and lobulated counter. Ridges and grooves in that appears in the margin secondary to scalloping falsely appears to be trabeculae. These are known as pseudo trabeculations. So other modalities of diagnostic modalities are CT scan and MRI scan. So CT helps to define a cortical integrity, the cortex is intact or not, and confirms that there is no mineralization of matrix, unlike other cartilage tumors. Okay, and MRI helps in preoperative planning and staging of this tumor. So differential diagnosis of this chondroid myxoid fibroma would be cyst of the bone cyst, like unicameral bone cyst or aneurysmal bone cyst, chondroblastoma, fibrous dysplasia, and giant cell tumor. So coming to treatment plot, chondromyxoid fibroma and block excision of that tumor. So recurrence of the after curettage are common. So we'll go for en bloc excision of this tumor. Thank you. So today we have discussed about osteoid osteoma and chondromyxoid fibroma. So in osteoid osteoma, the main silent features are it is a benign bone forming tumor. Okay, usually it occurs below the age of in second decade of life, second point, and mostly it involves femur and appendicular skeleton, and mostly femur or tibia. 50% case involve femur or tibia, and the characteristic feature of this is you can see it pain is relieved by taking salicylates like aspirin. So in excess, this important feature is that, so we can see a nidus, which is, we can say a nidus surrounded by reactive bone formation. So in treatment part, mainly it is a surgical removal of lesion, and you have to, important of the surgical part is that we have to remove the entire nidal tissue. So we have to identify nidal and other treatment option, radio frequency ablation. These and the silent features of this chondromyxoid fibroma are, is a rare benign cartilage tumor. It also has myxoid and fibrous elements, and common locations are proximal tibia and fibula and a distal femur, that is around the knee joint. So silent features of extra findings are, we have the extendable placed lytic lesion, and we have a sclerotic margin and pseudotrabeculations. Treatment is en bloc excision of this tumor. Thank you.